I was thinking about the whole 20 by 20 thing. So what's up with 20? Well, two things. Worst case, no matter where you start, you can solve any Rubik's Cube in exactly 20 moves or less. 20 is also the unique sum of three numbers in the Fibonacci sequence, a number series that's found all over nature, whether pineapples, artichokes, nautilus, seashells, even the way we use our hands. But I digress. What I'm really here to talk about is a new paradigm for out-of-hospital medical care. Talking about healthcare reminds me of one of my favorite lines in the film No Country for Old Men. It's a mess, ain't it, Sheriff? And the sheriff replies, if it ain't a mess, it'll certainly do till the mess gets here. We spend about $2 trillion a year on healthcare in this country, but our quality of care and measurable outcomes basically suck. Only 25% of hypertensives have adequate blood pressure control. 20% of people with heart disease meet guidelines for cholesterol. 90% of us will be overweight or obese by 2036. 1 in 10 of us are currently diabetics. By 2050, it'll be closer to 1 in 3. And the U.S. ranked last in preventable deaths among 19 of our economic peer countries. So, what's up? As the sheriff says, there are no clean getaways. As our population ages, the prevalence of chronic disease increases too. This, coupled with limited availability and access to primary and preventative care, leads to a model for health care delivery based on episodic care of acute illness, and therefore a revolving door in and out of the health care system. And just how dangerous is all this? Compared to what, the sheriff says? The bubonic plague? With limited primary care, people utilize 911 and the ER for non-emergencies. The ERs get overcrowded, ambulances back up at the door, and sometimes even have to divert elsewhere. The net result was less 911 resources for critically ill patients or for time-sensitive cases like heart attacks and strokes. Bottom line is that this leads to inappropriate or inadequate care and to increased costs all around. Imagine a 5-year-old with a sore throat waiting all night in the ER instead of going to the doctors. And imagine no ambulances available for the next stroke, heart failure, or cardiac arrest. And what if there's a Hurricane Sandy or an explosion in Rubbertown and the system's already functioning at capacity? What about the impact on hospitals and ERs? ER visits have increased twice the rate of growth of the population at the same time that hospitals and emergency rooms have continued to close. 90% of our hospitals are overcrowded, 40% on a daily basis. To add insult to injury, research shows that half of these patients would have done just fine with a scheduled doctor's appointment. And then there are the abusers, the patient who calls EMS to fetch her TV remote, or no joke, the guy who calls from Burger King because the server won't make it his way. And then there's this interesting case study from Austin, Texas. Just 9 patients accounted for almost 3,000 emergency room visits over 6 years, with the cost of providing this care about $3 million. And as is typical in this population, these patients all reflected a confluence of socioeconomic and other factors, including homelessness, drug abuse, and mental health problems. So what about the uninsured? Actually, only 1 in 5 use the ER for their primary care, and less than 2% are frequent ER users. But here's the real problem. They're at very high risk in that they often don't know they have a chronic condition like high blood pressure or diabetes, and so they're even less likely to control it. Bottom line, they have a 25% increased risk of dying compared to patients who do have insurance. And we're not alone. The system in England has been overwhelmed too, with what is almost equal to half the population making 1 visit to the emergency room every year. Again, patients are older and sicker, more people over the age of 60, than there are people under the age of 16. People are living longer, so they have more chronic problems to treat as well. So let's look at just one segment of this population right here in Louisville, patients who are insured by Medicaid and Passport. About 1/3 of all their visits to the emergency room and the costs associated with these visits are for low-severity problems. And interestingly, 75% of these people come from 10 essentially contiguous zip codes. So what are we up to? Well, I always used to think of pre-hospital and out-of-hospital emergency care as meaning essentially the very same thing. But pre-hospital care refers to the care you receive before we take you to the hospital, suggesting that we're going to get you there one way or the other. Out-of-hospital care, on the other hand, might mean maybe you don't have to go to the hospital in the first place. So we recognize that inappropriate utilization of 911 and the ER results in increased costs. But our underlying philosophy is not really about that. It's really about getting patients where they need to go. Let quality of care and value drive resource utilization and cost, not the other way around. We want to build a system around our healthcare needs rather than shoehorning patients into the system that already exists. So the new design model we're proposing is to divert non-life-threatening 911 calls to other sources of care. Utilize non-emergency transport to get patients where they really need to go, or bring care directly to the patient. What we'll get is better quality medicine, improved resource utilization, and decreased overcrowding, as well as decreased costs to insurers and taxpayers. So what we've done so far is this. Operator at 911 identifies low-priority calls and transfers them to a specially trained nurse. The nurse interviews the patient, utilizes a specialized algorithm to drill down on the diagnosis and the time to treatment. An appointment is scheduled at the doctor's or at a clinic or urgent center, and transport is arranged, whether an ambulette, taxi, or non-metro ambulance. The other thing we're going to do is focus on heavy users, not just the individuals, but high-frequency addresses like low-income senior housing and homeless shelters. We also have our Platinum Preferred members, people that call us 3 times a day. But heavy users can also be corporations and even government, who often have to shoulder these costs for 911 and for ER visits as well. So to address these cases, we're going to launch a preemptive strike, getting them to the care they need before anybody even thinks of picking up the phone to call 911. Nurse practitioners, medical students, social workers, and community paramedics will run clinics at shelters and at senior housing facilities or visit patients at home. They'll either treat on scene or make referrals to doctors' offices, clinics, social services, and even Meals on Wheels. And for those who call us every day, we'll give them some very special attention. Our goal is to enroll them in a multidisciplinary care plan, say with a specific hospital or clinic system, what we call a medical home, and thereby make sure they don't keep spinning around aimlessly in the system's various revolving doors. Finally, we're going to focus on high-cost users, those patients, say with heart failure, who leave the hospital only to be admitted over and over again. Not only do they do poorly and run up more costs in the long run, but each time they come back, hospitals now have to pay heavy financial penalties. We want to enroll these patients in case management, evaluating them regularly, making sure they take their meds, and getting their appointments when needed. Again, the goal being to keep them out of the hospital. Thank you.